be one of these last presenters, so feel free to get up and stretch if you need to momentarily during this presentation. So I want to take a little bit of a different spin on antimicrobial stewardship, and we're going to talk a little bit about outpatient stewardship. So many of us here probably have pretty established inpatient stewardship programs given the requirements of Joint Commission, but outpatient stewardship has been a little lagging behind, and so we'll talk a little bit about maybe how we can start involving stewardship in the outpatient setting. I have no disclosures, financial or otherwise, to provide. So just a few objectives here when we're complete. I want you to be able to explain why we need antimicrobial stewardship in the outpatient setting, to identify some barriers and possibilities for improving prescribing, evaluate the evidence that exists out there for outpatient stewardship, and then how to develop a clinical pathway at your institution. So I'm going to kind of skim through this pretty quickly because I think we all are aware of what antimicrobial stewardship is. And really, we're all trying to do the same thing, in that we're trying to educate and encourage better use of antibiotics and ensuring that we're getting the right drug, dose, frequency, and duration for antibiotics, and that we're getting those from the get-go. So we're training our prescribers in order to make this happen, but also educating our patients and families so they know what to expect. So why outpatient stewardship? So we heard a little bit this morning about some of the staggering statistics in regards to outpatient utilization of antibiotics. But we know that 60% of antibiotic expenses occur in the outpatient setting. And between 2010 and 2016, we actually spent over $33 billion in antimicrobials. So we have a lot of opportunities to decrease that cost. We also know that 85% of antibiotics at least are used in the outpatient setting. So albeit we have focused a lot on inpatient stewardship programs, that's really only going to be affecting 15% of that utilization. If you look at some of the national prevalence information that's out there on the CDC website, they looked at a study that showed that 30% of outpatient antibiotics are actually not even necessary. And so that obviously is a number that we could do away with, if at all possible. And that 50% of those who do receive antibiotics in the outpatient setting actually have the wrong dose, drug dose, or duration, with duration being one of the most common errors that occur. So this is a little bit, so if you look on the CDC website, they actually provide some guidance, and this is information from 2020. So they actually periodically will report this information. So it is a couple of years old, but I think it's really important to look at the antibiotic utilization as it is depicted here. So in 2020, we used over 200 or almost 202 million prescriptions for antimicrobials. And as you can see here, we're not doing too bad from the top drug choice, in that is penicillin-based products. But you can still see on here that there are still some opportunities for improvement. So we never like to see that our increased activity beta-lactams or higher generation cephalosporins or beta-lactamase inhibitors are starting to become more common. And if you look at some of the top antibiotics that are prescribed, you can see that things like azithromycin are still on that top 5 drugs. They also looked at it from a perspective of who was prescribing this. And it's not a big surprise that the leader of that pack are going to be our PCPs, our primary care providers, followed very closely by our APRNs and PAs. And I think that number is quite high, and probably because if we think of where a lot of those individuals are working, it's a lot of urgent cares and PCPs. So they are going to be one of the individuals that are being exposed to acute care situations that may in fact need antibiotics. The one that I did find a little bit concerning, or more concerning than I realized, was dentistry. So dentistry is actually third. And so when I think of dentistry, I don't think that they need to be prescribing quite that many antibiotics. And so that probably is another opportunity for improvement. I think for me, the big take-home message here is if you're trying to implement an outpatient stewardship program, that the people who prescribe the most antibiotics are probably where we would want to start. So this would be our lower hanging fruit. So I think this is fine, but how many out there have heard this? Well, that's fine, but that's their problem. I don't have that problem, or I'm better than that. And so I think the question becomes, well, are we? So I think this graph has been, or this picture has been displayed throughout the program. And if you look at this, we are not better. Nebraska is not any better than anybody else. And in fact, we're probably towards the bottom of the list. So we have one of the highest rates of antibiotic use per 1,000 population. And you can see we're over 700. And so this is something that we are all here to try to improve. And hopefully we can find ourselves slowly getting closer to at least a lighter red. All right, so before I talk about this, by a show of hands, how many of you guys have an established outpatient stewardship program? Okay, what about an inpatient program? Okay, which is exactly what I expect. And this study proves exactly that. So for those of you, because you can't see from the back of your heads, there were only a couple of hands raised for ambulatory stewardship programs. So don't be surprised if that you are not the only one. Most of us do not have that type of a program. So this actually was a study that used a major national organization that oversees over 3,200 academic institutions, as well as over a lot of ambulatory settings as well. And so this was a cross-sectional, multi-center study that they did. And really what they did was they sent out surveys to all of the people that are part of this program. And so they sent out over 1,600 surveys, and you can see here that they didn't get a great response. They had 172 responses. So actually, only 129 of those were able to be included because some of these surveys would go out to more than one individual within the institution. So if two people submitted the same information, then they only utilized the one survey. 9. Only 9 of those 129 facilities had an antimicrobial stewardship program for the outpatient setting. So just as we see here, it's not a very common practice, and this is something that we can improve on. 57% had no program at all, and the rest of them maybe had some form or were trying to develop some program with in antimicrobial stewardship, but it had not been established yet. Action items that they did mention that they did included 45% of those actually had clinical pathway guidelines. So guidance for UTIs, sinusitis, pharyngitis, and otitis. Those were the most commonly reported clinical guidelines that they had. And then they also showed that 21% had set up one goal. So albeit if they didn't have a robust program, they may have had a few action items that they were trying to implement in the outpatient setting. They also commented on a variety of other things that they did, whether that be physician incentives. They could also do indications on antimicrobials, so they had to select something. And then there was others that they had to document in the medical record more specific information, although that was a small percentage of organizations that did that. One of the things that we do not do well is metrics. And so a lot of programs, even inpatient programs, have these goals and have these clinical pathways, have these algorithms, but we really don't measure compliance or outcomes related to those. For those centers that did, they actually found that it was very beneficial. And I think this is something that we all can try to do a little bit better. But they found that only 18% reported that they did it, but of those, 94% saw a reduction in antimicrobial use. So clearly, it does make an impact if we can provide those stakeholders and end users with that data. So barriers, I think we are all very well aware of barriers, and these do not differentiate whether you are inpatient or outpatient. And the first one is really support. So we need support to be able to do this. We need leadership to acknowledge that this is important. We also need staff. So especially once we get outside into rural communities or critical access centers, we don't have the people. We don't have the ID specialists. We don't have the pharmacists. And so we need to be thinking about how we can utilize other individuals to assist in this outpatient setting. Time. This is the biggest barrier that is reported amongst stewardship programs, is we don't have the time. And we all know that COVID did not help that at all. In fact, I would say most of us have potentially even regressed in our ability to do stewardship. And so we need time. We need more time. And for those institutions that are doing stewardship, many of them are doing this as an extra part of what they already did. And quite oftentimes, those centers that do have programs have a very minimal amount of physician FTE, less than 0.2, and most of them have no pharmacist FTE. And so we have to start thinking about how, again, we can go back to get both the leadership support as well as the personnel to be able to do these things. Funding is another one that, again, starts with leadership support. So I don't know how many out there of you guys have had to do this, but we oftentimes have to support our need. And so in data, we have to support that we have seen a reduction or some sort of need assessment in order to get that funding. I'm going to go through these pretty quickly because we have talked about this multiple times throughout the day. But the CDC does have core elements, and these do even go into outpatient settings. They actually have a whole section on outpatient antimicrobial stewardship and a lot of resources on the CDC website. So I do encourage you to look at that as you're trying to implement a program within your organization. Additionally, the Joint Commission now requires outpatient stewardship, and so this occurred in 2020, and it's very similar to those requirements of an inpatient setting. I think the only downside to this as of right now is for organizations like my own. Our ambulatory sites fall under our hospital. So I am not required to meet these at this point until they change their inpatient requirements, which require us also to do outpatient stewardship. So there's a lot of loopholes in this that have allowed organizations to escape the requirement of having outpatient stewardship. So we're going to talk about clinical pathways now, and this is actually one of the action items that is listed on the CDC website. And I think a lot of institutions have these for inpatients, and there are more and more institutions that have these in an outpatient setting. So just as a reminder, really clinical pathways are task-oriented and time-sequenced plans of care. And so these are going to be, the idea is to make this not only improve the quality of care, but also to decrease the variations in practices so our patients are getting consistent care. It does need to be multidisciplinary, so we need to involve a variety of people from multidisciplines, but we also need to think of how that pathway is going to flow. So we shouldn't just focus on diagnostics or treatment, we really need it to include all of that. It should be a stepwise approach so that somebody can actually look on there. For example, July 1, for those that are at academic medical center, it's always good to have a step-by-step approach so that even people who aren't as familiar with it know exactly what needs to be done next. And then we need to provide time frames or criteria-based progression. So if this, then this. If the lab changes to this or the patient deteriorates, this is what your next step is going to be. And lastly, just standardizing the care for a specific clinical problem or procedure is really ultimately what these pathways are designed to do. So that's great, but how well are these supported in the literature? There were some other great recent publications that were presented this morning, and I did not include those for today's talk. So these ones are a little bit prior to those. But we have Lee et al. That actually looked at an urgent care setting, and they picked urgent care because they had the majority of their prescriptions were written for antibiotics in the urgent care setting. So they selected 2 urgent care centers that were pretty equivalent, meaning they had about the same number of patients, kind of the same patient population, and they also had consistent providers that were unique to each of those different centers. They then used one as the control and one as the pilot or the test program. And what they did is they created guidelines for the conditions of acute respiratory tract, skin and soft tissue, UTIs, et cetera. And then they provided education to all of the team members. So there were 3 physicians and 3 APRNs that worked at each of these centers, but again, only one center received this education. Of note, they also gave them pocket cards or resources to also refer to when they were actually back at their settings and taking care of patients. What they found was that they found a significant improvement in the guideline concordant activity between the 2 programs. So they saw a 20% increase in concordance. So they had 50% in the control group and 70% in the patient or in the facility, the urgent care facility that went through the program teaching. Moving on to another study, this one was actually within a VA system in both Tennessee and Kentucky. And so what they found here is that they focused on a specific condition, so acute uncomplicated bronchitis, and they chose this because 85% of patients with this diagnosis received an antibiotic. And so they really wanted to focus on this particular indication. This facility used a lot of different pieces in order to accomplish their end goal. And so what they looked at was that they did a needs assessment first, which is going to be imperative for any of your clinical pathways that you develop. And they met and got 80% of their physicians provided feedback as to how they currently order or go through their process of thinking about prescribing an antibiotic. Then they provided some educational materials. So they developed their clinical pathway, and then they educated those physicians on why and how that clinical pathway was going to work. They also provided the clinics with posters as well as pocket cards, any type of information that they could use to refer to when they were trying to implement this program. Then they did audit and feedback, and I think this is something where we talk about the collection of the data and reporting that back. They did this for all providers, so they provided a monthly report to all providers that were within these facilities. And this was extraordinarily time-consuming, as we can all imagine, to create individualized reports for each of those physicians. And also what they found out is that a good portion of them never opened the email. So it was a complete waste of time if you're not going to read that information. And so what they then changed to was that given that they found that if we did data collection and provided that information back, it was a very high resource with low utilization. And so then they changed to targeting the high prescribers. And they found that 14 of their prescribers out of 106 accounted for 55% of their antibiotic use. So just focusing on those 14 individuals, they could clearly handle that a lot easier than the 106. And so they provided quarterly reports back to those individuals, but they also took it a step further and did clinical reviews of those top prescribers. And so they would review patient cases and then give them feedback on potentially how they could improve compliance with that guideline. And lastly, they did grand rounds. And what they found, I'd already shared a little bit about the audit and feedback, that people didn't read that when they used it for all people. But if you focused on that high prescribing group, so low performers, they found like that was actually didn't take as nearly as much effort, but it actually gave you the most bang for your buck. So you had the most response. And they were able to reduce their antibiotic utilization by quite a bit. So I think the next question that always comes up is, well, which pathway do I begin with? Kind of where do I start? And I think there's not one right answer to this. This is really going to depend on what you have going on in that particular setting. So you need to do a needs assessment. And as we mentioned in the previous presentation, that this may take some work with IT or using your EHR system to retrieve that data. I would also suggest picking something that has good evidence-based medicine, so maybe something that has a national guideline that has already been established. And then what setting or what environment can you engage people with? So whether that be nurses, physicians, APPs, PAs, whatever it may be, who are you going to be able to get to engage in this? And then what resources are you going to have available to give these individuals to try to implement a program or a guideline? And then metrics. We need to be sure that we can gather metrics both before and after the pathway so that we can enhance communication, but also sustain the ability to continue to perform. So where to begin? And this kind of goes along with the CDC's recommendations that we really need to identify leadership. So, and when I say leadership, this is leadership from the Pathway Committee. And somebody needs to kind of own this committee and kind of be responsible for ultimately for the communication, as well as keeping everybody on track. Then you need to identify the pathway team members. And don't think just with maybe a physician, a pharmacist, a nurse. Think more broadly. You're going to want to have lab potentially involved in here. Maybe radiology needs to be involved. So think of all of the people that you would want involved on this pathway, and certainly even invite some of your stakeholders, which is really the next step. So who will be affected by this pathway? And it's everybody. And I know I heard one institution today that said, you know, even the receptionist or the people greeting patients can really change what that expectation is for those patients. So really think broadly about who your stakeholders are and start engaging them. The more you engage them, the more successful you will be. And identify operational members. So this is something that we need to think about. We can't do it all. I do not have a marketing degree. I am not able to communicate with all of these other facilities or urgent care centers or CP clinics or whatever it may be. So you need to involve IT, you need to involve marketing, and individuals that can help you with that education, your educators potentially. And then that committee needs to determine the goal. So what is the goal of this clinical pathway? And maybe you have more than one goals. And then, as we've mentioned several times, is how are you going to measure this? What is going to be your metric for success? And who is going to be responsible for that? So the clinical pathway team are going to have to answer all of these questions. And we kind of touched upon some of these already. But the other thing that we need to think about this team is that it is, in fact, a team. So we need to have engagement from all team members. And as I also mentioned, that part of that team should be some of those stakeholders so that they have not only a say, but then that can also be one of your boots on the ground people that can support it and be an advocate for it at that particular location or setting that you're trying to do this with. So what needs to be included in your clinical pathway? And I would say there's a variety of things that people include in there, but these are some of the things that I think are the most important. So you need to have an objective of the pathway, but you also need to give rationale. You need to explain to people why they need to do this. Because if you can't explain the why, then I'm probably not going to do it. So be sure that you're providing them that information. You also need to decide who's going to be included or excluded from this pathway. So certainly, you can have a community-acquired pneumonia pathway, for example, but there's going to be certain criteria that maybe you don't want them on there. So if they're a cystic fibrosis patient or a trached patient, that's probably not a patient you want on that community-acquired pneumonia pathway. So be sure that you have both those criteria on there. And then what are the clinical signs and symptoms that are going to make a patient follow that pathway? And I would be very specific. So not just O2 needs, but SATs below this number, oxygen requirements above X. Whatever it may be that you want to have on that clinical pathway, be sure to be specific. The next thing is diagnostics, and this is important whether you're inpatient or outpatient. Do you need additional tests? Do you need radiology? What do you need to help make that diagnosis or drive clinical treatment? And that needs to be very specific, again, giving exact numbers. Your CRP is this. Your chest x-ray, whether that be a 2-view or a plain, whatever it may be, we want to be sure that we're providing that information. In your longer executive summary, you can even include things that like the most common pathogens. And I think that's important to kind of help maybe those individuals who are less familiar to connect the dots. So these are the common pathogens, and that's why we're going to use this as the most common treatment. So if they realize that azithromycin is not going to be the drug of choice for all pneumonias, that it's really indicated for specific indications. And then within the clinical management, be sure to include things that's all clinical management, so not just antibiotics. Think of anything that you would provide to that patient. Maybe it has no antibiotics at all. Maybe it's more symptomatic or something as a humidifier or saline rinses for sinusitis, things that aren't necessarily prescription-based. And then those metrics plans. So that kind of ties back through your objective as well, what you're trying to achieve. Those should kind of go hand in hand. And lastly, we need to be sure we're giving them the resources and the references to refer back to, but also to understand our reasoning for doing this and have the resources to even show families if they want. Posters, we heard that earlier today. Something as simple as putting a poster in an outpatient setting with their signature on it and picture can actually promote better antibiotic use. So now you've developed your pathway. Now what do? Education, and this is huge. We've got to give education to those end users. How you do this is really up to your facility and what resources you have available. Some will actually do hands-on, some will do some electronic method, others do it via email, an article they have to read. There is a million ways that you can do this, and I think you need to tailor it to your individual setting. Be sure that you're using all members of your team. So don't have one person just responsible for this. Be sure to use your IT, your marketing, all of those individuals on the pathway committee to help spread the word. We also want to make sure that when we're educating, that we're giving them the information about when this is going to occur, what the expectation of that stakeholder is, and also if there's any consequences for not complying with this pathway. And then resources, as I've mentioned multiple times. So these are just some pieces of education. These happen to be found on the CDC website. And again, this is on that website that I had said I encourage you all to go and use, because this is just a snapshot of what they have. But you can see here there's one for otitis media, and then there's one for bronchitis. And it lists just generic things that the families they could give this to a family, for example, so that they understand maybe why they didn't need an antibiotic. But it also, it gives that provider that's in that setting who's trying to decide whether to not give an antibiotic or if they're getting resistance, to provide some guidance to families. I wanted to give some examples of clinical pathways that exist out there. There's one here from Children's that is on acute otitis media that we use in our outpatient setting. The second one is actually one out of CHOP. I encourage you, you'd be surprised what you can find on the intranet. Most people, organizations actually have these available for you to see. And there is no sense in recreating the wheel, albeit you shouldn't probably do it verbatim from them without getting permission, but it gives you some idea of where to start, some things that people have included. It also is important that you tailor your clinical pathway to your setting. So for example, you probably will not find the same guidance among all centers, because maybe my antibiogram would tell me that I can't use clindamycin, for example, as first-line therapy for a skin and soft tissue infection. Maybe I have too much resistance to that, and so I may give you another option like Bactrim or even linezolid in other settings. Also included, so the first one there was really kind of a what I call a pictogram, but a step-by-step easy instruction process on a flow chart on where to go with each patient. But with that, you should have a little bit more extensive explanation as to why and how you got to that algorithm. And so these are what I call like an executive summary that specifies all that rationale in the pieces of the pathway that I had mentioned earlier. This is where that goes. So if somebody really wants to dive into the whys and the hows and the metrics, they can go to this document here. And again, the first one is from Children's, and this second one actually is from Nebraska Medicine. Again, these are readily available on the internet. So you have done your education. Now you have to, sorry, try here again. You've got to implement your change. And this is, I think you do a lot of work before and you do a lot of work afterwards. But implementing the change is really when we just kind of bite our teeth and hope it goes well. The metrics are really when we find out how well we did and how well it's going. I think one of the first things that we need to do before we roll this out, and as many people have mentioned today, is to validate your data. So we need to make sure that our pre-intervention data is accurate. And so I too, as our last speakers mentioned, have fallen into our data, something didn't match up right, and we discovered it a couple of months later. So it's important to really keep validating that as you go through the process to make sure that some update or some change didn't affect your data. You need to develop automation if at all possible, and our last speakers talked about different methods of doing that, whether that be your EMR, EHR, or using a third-party program. But this is going to be helpful if you're going to try to mass produce data so that you don't have to do it via requesting a report from IT and putting it in Excel and then trying to make individual reports. It can be done that way if you are a resource limiting location, but it is much more time consuming than if you can use some of this automation. And by all means, share this with your stakeholders. So I think one of the big things is a lot of institutions have implemented this. They showed success, and then we gradually end up seeing that progression ends up, we kind of revert back to our old habits. And so one of the big things that we can do is to show people that work that you're doing is making a difference. There's nothing more dissatisfying when you think you're just doing more work just to do more work. So if you can see that we're reaping benefits from all that work, suddenly I become much more likely to continue to do that intervention. Here are some examples of some metrics that we use at Children's. So we have a variety of clinical pathways, which is great, but you need to make sure that you're actually using those clinical pathways. And then this is readmissions or revisits back for that same indication. And this can often be looked at through your EMR system. You can also break it down by individual providers or even facilities. So if you want to try to take advantage of those people who want to be high performers, you can publish this data. Or if nothing else, this may give you, as the pathway committee, insight on who to focus on. So I already talked a little bit about sustainability here. These are the things that I really think in order to sustain good practice that we need to all include in our processes. Oh, didn't realize I was going to do all that. One more. So I want to close with just saying this is a quote that I really feel coincides with what we all do, and that alone we can do so little, together we can do so much. So I thank you again for your time and open it up for any questions you may have.